Hello, everyone. I'm very pleased to welcome you to the UCSF course, Everything You Need to Know About CT, Maximizing Quality and Safety. I know many of you joined our Meet the Professors this morning. I'm thrilled. I hope you all continue to take advantage of those opportunities in the morning, at the beginning of the course and the end of the course. We are really excited to have participants for this course from around the US, but also internationally, including people from Canada, the Czech Republic, Iraq, Israel, Italy, New Zealand, Norway, Portugal, Romania, Saudi Arabia, and the UK. I'm also pleased to see that we have so many of you from diverse backgrounds, including radiologists, nuclear medicine experts, medical physicists, technologists, but also nurses, cardiologists, pediatricians, oncology and sports medicine physicians, as well as an emergency medicine physician. We have an exciting program to share over the next 3 days, focused on maximizing the quality and safety of CT. The speakers have interesting perspectives, expertise, and knowledge to share, and we look forward to an interesting and I hope interactive meeting as much as possible given the webinar format. I hope you share your experience and your questions through the chat and Q&A functions. Please take advantage of the Meet the Professor sessions. As I said earlier, I think they're a really great opportunity to have your questions answered. We would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land that we are currently presenting from. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. A few Zoom webinar questions. Please use the Q&A button to submit your presentation questions to the speakers. The chat button is available for you to interact with other attendees and panelists. And if the panelists want to submit questions to other panelists, you should also use the chat button to do so. If you need technical assistance, please send a chat message to the panelists and someone will reach out to you to help. If you need closed captioning, click on the CC button on the bottom of your Zoom screen or hit the 3 dots at the bottom and then check Show Subtitles. There's a syllabus website. The link will be shared in the chat. You can find the slide sets for the talks and a link to complete the speaker survey and a link to the virtual exhibit. Please visit the virtual exhibit during the breakouts. The lectures will all be recorded and will be posted on the course syllabus next week. That is the end for the introductions. Please feel free to ask questions starting any point in any of the talks, and then they'll be addressed during the Q&A section at the end of each talk. So I'm going to be giving the first presentation. The title is Radiation from Medical Imaging with Computed Tomography, a Medical Triumph Fostering a Silent Epidemic. I'm going to be giving several talks at this meeting, and my disclosure for each is the same. I'll give you all just a few seconds to read it. So computed tomography was invented in 1967 separately by 2 doctors, Dr. Hounsfield and Dr. Cormack. They together received the Nobel Prize in 1979 for this development. I want to point out, I forgot to mention that I have an outline on the bottom of my talk. So if you get lost or distracted, you can remember where we are in the presentation. The design of the CT scanner was absolutely revolutionary. There was the design was using X-ray simultaneously to image large parts of the body and then using computers to reconstruct those images. The adoption of CT was extremely fast. The first scanner in clinical practice was in 1971. There's a picture on the slide, which is not the first CT, but was one soon after. And it bore little resemblance to the current CT scanners. It took hours to scan the patient, and it took days to reconstruct a single image. But nonetheless, within a few years, 1973, there was a first head CT scanner installed in the United States. A few years later, the first body scanner installed. And by 1980, a rapid dissemination, CT was widely available. We performed in the US alone 3 million exams that year. By 2020, it's become extraordinarily common. In the US alone, we have 10,000 plus CT machines. They operate 24/7, and greater than 90 million exams a year are performed with CT scanning. While the development of CT was truly revolutionary, its evolution has been even greater over the 40 years. If you look at these three sets of images from the earliest CT scanner to one 10 years later to current, really you could see how the phenomenal engineering improvements really led to far more greater detail and clarity, anatomy, physiology, and these improvements have really led to far greater uses for this technology. In current practice, the areas of use are vast, including everything from stroke care, vascular disease, cancer, trauma, pain, lung disease, and for screening for a whole large range of indications. In the most recent images I'm showing, you're not seeing only anatomical detail, but you're seeing blood flow that impacts clinical decision-making across many areas. So the technology has really gone through amazing developments. And because of its improvement in detection and showing all kinds of function, CT has expanded into basically every setting where healthcare is provided, be it inpatient, outpatient, emergency room settings, or even private offices. And it is adored by patients and providers alike. Additionally, its high profitability, which has been there from the beginning, increased the number of scanners. And then once the number of scanners were increased, the number and types of physicians who owe them and the number of scans that we're doing. An industry of radiologists willing to cover readings overnight, usually based in a different time zone, allowed near universal access to CT scanning 24/7. By 2010, the growth in CT imaging was faster than any other area of healthcare services. There were occasional red flags, not very many, but there were some false positives. Issues were raised about overuse in cost. But for the most part, it was considered to be really only beneficial without any harms. So unfortunately, I can't collect your answers, but I want you to think about it for a second. This is in the US, and we do more CT scans in the US than any other country. How many CT scans do you think we do annually in the US? And we'll go circa 2018. Was it 1 in 100 people have a CT scan each year? 1 in 50, 1 in 25, 1 in 10, or 1 in 5? And by how many people, I really mean how many scans were performed. I usually ask when I do this presentation in person for a show of hands. And usually there's 1 or 2 people in the audience who get the answer right, but not usually very many. What this graph shows is the number of CT exams per 1,000 people per year over time. So you can see on the x-axis, the graph goes from 2000 to 2016. The upper set of lines shows the number of CT scans performed in older adults, those older than 65, the lower in adults 18 to 64, and the right in children. And there's solid lines and dotted lines. The solid lines represent imaging rates in the US, and the dotted lines in Ontario, Canada. This was an international comparison. And what it shows is that the rates have continued to rise. We've published a subsequent paper that showed the rates have continued after that time. And basically by around 2016, in older adults, we were doing 400 CTs a year per 1,000 US citizens. So a tremendous number. The rise has continued, much less imaging in younger adults and even lower imaging in children. If we look in children, we're talking about in the ballpark of 20 CTs per 1,000 people as opposed to 400 or 100. So the correct answer on that question was really in the ballpark of 1 in 4 adults gets a CT scan in the US every year. So 3 newsworthy occurrences happened within a few months of each other that really changed the perception of CT safety. And this happened really overnight. And these led to patients and physicians and policymakers question the widely held view that CT scanning is always completely safe. The first, which these images are from, there were several media reports of radiation overdosing. It was initially reported as having occurred at Cedars-Sinai, but then it spread to many other hospitals. These dosing errors from CT scanning led to doses that were 100-fold higher than needed and resulted in acute radiation sickness. You can see these very dramatic bands of hair loss that reflected acute radiation effects. Again, the initial report was a few hundred patients, but that was expanded to a few thousand patients, with many other hospitals reporting the same problem. The doses that these patients received were in the ballpark of doses we use to treat brain cancer, not the ones we use to make a diagnosis. In addition to the radiation overdoses, the overdoses led people to understand that CT machines are capable of causing harm. There were two additional pieces of information that made the press. The second was a single child who was irradiated 15 times in Northern California. And so this led people to understand that not only is the machine capable of causing harm, but that operation of these machines is incredibly important. The technologist was having trouble seeing the images, so just kept pressing the scan button and ended up getting scans of this child over and over again. And then lastly, there's a paper that came out of UCSF in the Archives of Internal Medicine that showed that the radiation doses associated with routine CT were highly variable across hospitals, and that for some patients, particularly younger patients, the risk of cancer was as high as 1 in 100 in these scans. And this was a slightly different message. This said that there's little consistency in the day-to-day practice, and that the variation could result in high risk for some patients. In addition to these three occurrences, a few months later, a New York Times reporter subsequently published a series of articles related to radiation dosing for radiation treatment for cancer, showing that there were errors and that these errors led to several deaths. So these three occurrences, the series of articles by Walt Bogdanich, really raised public awareness and concern regarding the safety of medical radiation. So we get to radiation doses for CT in general. CT scanning, as all of you know, use far more X-rays than conventional radiographs, maybe 500 times to 1,000 times, depending on what kind of study is done. There was pressure from manufacturers to compete on image quality, and in order to compete, they kept generating higher and higher quality images, and this resulted in the type of CT scans that also generated far higher doses in order to generate those images. I want to say that it wasn't necessarily obvious that the technological advances would lead to higher doses. It could have led to lower doses, but the way the technology was used and the drive to compete on image quality led to higher doses because of how it was used. As an example, the brain perfusion scans that led to those radiation overdoses that led to the awareness with people losing their hair, even when they're done correctly, those were done incorrectly, but even when they're done correctly, they deliver a dose 10 times higher than a routine brain CT. And that type of exam was used routinely prior to the overdoses. So because of the technological advances, we can scan in a matter of seconds, obviously not the hours of the first scan, but not even the minutes of many of the early scanners. We can scan in seconds. That was used as an impetus to develop scanning procedures where we would scan patients over and over. I'll talk about that a little bit later in the multi-phase. So the technology was advancing, and we used it to develop more beautiful images. So there were several research questions that I was interested in answering. What are the doses for CT? Are these doses a problem for our patients? And can we lower the doses without undermining accurate diagnosis? Obviously, what we are desperately trying to do with CT. And I'm going to go into three of these. I think the question about what are doses for CT was asking what happens in routine practice, which impacts millions of patients, very separate from how can you have errors where the dosing is incredibly high. Those are very different questions. They both need answering, but this question was, what are the routine doses that that were used in practice. So for the first question, what are the doses for CT? And I list a number of references below. My team at UCSF has led a large number of papers that have focused on quantifying the doses for CT. And these papers have all had incredibly consistent results. First, that doses are highly variable and far higher than needed for diagnosis, which we found in every study. We've collaborated, I'll show you some more information about it in the next few slides, with a large number of hospitals. And for each of them, the hospitals were surprised that their doses were in fact so high and so variable. There are no data that the higher doses lead to more accurate diagnoses, meaning higher doses may illustrate more things than lower doses, but not that those lead to better diagnosis or changes in patient management. And the variation in dosing reflects practice preferences, not evidence. The strongest predictor of a patient's dose is where they go for imaging, not why they're getting the imaging. And patients and providers alike, which has been studied in many papers, are unaware of these potential risks. So UCSF led a study describing data assembled in the UCSF International CT Dose Registry. The registry includes detailed data from in the ballpark of 16 million CT scans collected from 166 institutions in 7 countries. This was an NIH and PCORI-funded collaboration to pool data so we could describe what are doses, as well as to see if there were ways that we could lower those doses. In this graph, I'm going to show you several graphs that look like this. So I'm going to spend a little bit of time making sure that you understand this graph. It shows the radiation dose by institution for abdominal CT. This is focused just on abdominal CT. Sorted by the dose. So this particular graph is showing routine abdominal CT by facility. So each of these little box plots is one institution, sorted from the lowest to the highest dose. So you can see the variation between these lines because each of those light purple represents the 5th and the 95th percentile of effective dose. The dark purple and the pink and the yellow column are one institution, and the colors are by country. So the United States is purple. Most of our data come from the US. The purple are other, and the yellow are from Europe. This dotted horizontal line and the solid horizontal line show the 50th percentile in distribution for the entire registry and the 75th percentile for the entire registry. And these are scans that were collected through 2016. I think what you see here is a few things. First, that in general, the doses in Europe were on the low end. The doses actually in these countries are in Asia are on the high end, but the purple, the US, goes from in the best in terms of lowest dose to the top in terms of highest dose. And so some facilities have all of their doses less than the average, and other facilities have almost all their doses above the 75th percentile. This is supposed to show just how variable doses are. If we look at the effective dose on the y-axis, and I should mention, we'll talk about this later, but it doesn't matter what measurement you use, the results look very similar. But these are not small numbers. So while the average dose was around 12 millisieverts, some facilities had average doses that were closer to 35 millisieverts. I'm showing you here one slide just showing the averages by country, and these are showing the mean dose and the standard deviation of dose. High dose CTs we define as exams that have doses above the 75th percentile. It doesn't mean that all of those are inappropriate. Just in general, you don't want to have most of your scans above the 75th percentile. In Japan, we see that 69% of exams are above the high dose threshold, mostly because they use a lot of multiple phase studies. And you can see that in Europe, as on the graph, the doses tend to be lower. US, about 50% higher than in Europe, and then Israel and Japan higher. So this is tremendous variation in dose. So why are the doses so variable? That was what the BMJ paper was really focused on, using detailed data on the patients, age, sex, the reason for the CT scan, the type of scanner that they used, and the facility. We assessed why the doses were so variable. The radiation doses, which I'll show you more of, vary by all of these factors. Definitely you see different radiation doses in small, average, or large patients. But these variation in patient factors did not account for the large variation across institution and countries. And in fact, when we adjusted for patient size, the variation grew larger. The variation was mostly due to local decisions and protocols for scanning. We included a table in that manuscript. I'm going to show it to you again later, but I'm showing you a little bit of that table right now. And this is showing scans that were done for pulmonary embolism CT, so a pretty narrow indication. And this table is showing doses and technical parameters. I think there are about 30 or 40 lines of data in the table, and I've just pulled out several to highlight something. So this is showing the country, the effective dose, and again, the results are identical if we use any measure of dose, DLP, CT-dival, SSDE. It shows for pulmonary embolism CT, the effective dose ranged for this protocol at this facility from 1.7 up to 33.7. The KVP ranged from 100 to 120, the mean MAS 137 to 200, the mean pitch 1.5 to 0.8, scan length 30 to 40, and the number of phases per study, 1 to 2.8. These last two rows are showing you the summary of the 10%, I don't have that many on here, but 10% of protocols that were the lowest dose and the highest dose. And it shows you why the doses are higher. Again, this is one single indication. And this is, I didn't mention it, but it's the same indication and the same machine. These are data from a Siemens Somatom Def AS scanner. So the same scanner, differences, and these results were adjusted for patient size. So a huge reason for the differences is the highest dose protocols use 3 phases instead of 1. The reason these numbers are not whole numbers is because these are averages. So on average, the highest dose protocols use 2.7, obviously a mixture between some using 2 and some 3. The MAS is about 50% higher. The KVP was 100 versus 120, and the resultant differences in dose is tremendous. So this table is meant to say we're doing different things on our patients, and it's not because of what they need or the question we're trying to answer. I'm showing a graph from a separate study. UCSF is co-leading a study with UC Davis and Kaiser Permanente to assess the risk of cancer associated with medical imaging in children. As part of this study, we assembled data from across 7 U.S. healthcare systems and from Ontario, Canada. And this study, as part of doing this study, we also pulled the CT scans and quantified the radiation dose of 33,000 CT scans in children. The prior graph that I showed you is in adults. This is showing you data in children. And this is meant to again show you that the doses that children receive were highly variable, even after accounting for patient age, patient size, and the reason for the study. In children, there aren't that many reasons you do CT scanning, and yet nonetheless, the doses are different. So the same vertical box plot represents an individual institution. They are sorted by the mean effective dose. Here I'm showing you the mean colon dose. Because they're sorted by the mean effective dose, when we put them in the same order by mean colon dose, you can see the jaggedness and the differences between them. So this is showing that the mean effective dose is 10 millisieverts, but that some children got doses that were far lower. The 1,000th patient is about 5. The 4,000th is about 20, and the highest dose was received up to 90 millisievert. And the corresponding colon doses, the average was 17. And some patients received a dose that was higher than this graph goes, above 100 millisievert for a single exam. I'm often told that the variation is necessary and that we have good reasons for doing it. In my mind, this graph shows that, in fact, we're using doses that are far higher than anyone really is aware, and certainly far higher than anyone is deliberately using. I'm showing you a few more graphs from the same study, again, the REC radiation-induced cancer study. And this shows observed organ doses in children. I'm showing you one group. These are organ doses from head CT in children ages 0 to 4. It's showing you 3 organs: the brain, that's at the top, red bone marrow, and then thyroid. And I think this graph shows 2 very important results. First, that doses have come down a great deal over time, particularly the brain doses. From 1996, when our study began, the doses were as high as 90 milligray for a single exam. They're now far lower. So at first we see that the doses have come down. But second, we see that the doses are still not so low. So the brain dose for this 0 to 4-year-old is 40 milligray. I shouldn't say this. This is 1,000 children ages 0 to 4 years old is 40 milligray. And that number is a relatively higher dose than we would like in a young child. And just to remind you where we are, we're looking at the radiation doses now. I want to show you from another study, really to hammer home the message that the doses are highly variable and higher than needed for diagnosis. Pain from kidney stones accounts for about 1 million emergency department visits a year in the US. And since the 1990s, CT has become the primary test that we use. These results are from a 15-center randomized controlled trial that was focused on comparing whether we should use ultrasound or CT for imaging patients with suspected kidney stones. And this graph is from a paper showing what the resulting doses were at each of these 15 institutions. As I'm guessing most of you know, it's very well established that low dose techniques are sufficient for diagnosing kidney stones. This cohort of 2,700 patients included only patients that were at high risk for kidney stones and low risk for other diagnoses. There were some patients who had other diagnoses, but in general, to be enrolled in this trial, you had to be at high risk of stones and low risk for everything else. And in this study, so a highly selected population of patients who all were at high risk for kidney stones, only 5% received an appropriate low dose study. So again, these box plots are showing each institution sorted from the lowest to the highest. The box shows the 25th and 75th percentile distribution. That means if I went to hospital O and I lined up all of their patients who were enrolled in the study by the dose, I would see the 25th and the 75th on this line. This is the median and the mean, and this is showing distribution. The dotted line is showing a 4 millisievert low dose protocol. That's what we should be using. And almost all of the patients are significantly higher than that. So in the setting when we should be using low dose, we're not. So why are doses so high and so variable? I'd say there are many reasons. First, there are very few standards or guidelines for CT that exist. What is the right dose? A question that I get asked all the time for a particular study type is considered an esoteric question. Not this is the answer, but like, well, it depends. And that shouldn't be an esoteric question. We should have an answer to that question. There is no organization responsible for collecting or reporting dose. Technologists receive no consistent education on how to do CT scans, and radiologists determine the settings, but they don't know very much about risks or dose. The guiding principle of ALARA, something we'll come back to, is too vague to provide guidance. And in the absence of explicit guidelines, this introduces unnecessary harm. I want to point out that the US starkly contrasts with other countries where both professional groups and the government have been closely involved in oversight. So the FDA approves the CT scanner, but does not have regulatory oversight for how the tests are used. The ACR publishes average doses, but no radiologist feels compelled to have similar radiation doses, and they're not checked on a scan-by-scan basis. So that was the first question I said I was going to address. Are CT doses variable? And they are. Second, are the doses used for CT harmful? CT uses ionizing radiation, a known carcinogen. There is substantial evidence on the harmful effects of radiation. Very high levels lead to burns, hair loss, immediate harms. The doses we typically use in imaging are far lower, but nonetheless, DNA gets damaged and the risk of cancer is elevated. It's estimated through really impressive modeling that in the ballpark of 2 to 5% of all cancers in the US come from CT scan. In 2019, that reflects 30 to 60,000 future cancers from 1 year of CT imaging. But because these risks are delayed, they're very easy to ignore. There's been over 100 years of radiation epidemiology. You can see in this graph milestones of what we have learned about radiation over the years, but the data are really extensive. I've heard from many people that we don't know if radiation is harmful in the range of what we use in medical imaging. That's simply false. We have a lot of data, and there are two really not completely up to date because they're a few years back, but incredibly thorough publications. One in the US on the left, the Bear 7, and one on the right from the UK that describe and quantify all the data on the radiation harms from low dose radiation. They don't include recent data from direct studies of CT scanning, but each of these reviews is comprehensive, well done. They're actually both quite readable and really summarizes what we know about the harmful effects of radiation. Each of these publications estimates the risk of cancer based on different factors such as age and exposure, sex, and dose level. And each of these reports concluded that the doses we routinely use for CT will cause cancer in some patients. And the higher the dose, the greater the risk. In terms of the epidemiology that's covered in both of these reports, a large part of the data comes from 120,000 survivors of the atomic bombs, but also patients treated for cancer, patients treated for benign conditions, patients who receive repeated x-rays, for example, patients with scoliosis, radiation workers such as the nuclear power industry, environmental accidents, and then they don't include in these reports, but extensive data comes from recent studies and direct studies of CT in children, and there's mounting evidence in that category. The study of the atomic bomb survivors really has been considered the gold standard of radiation epidemiology. And the basic premise of these studies, of the people who survived the atomic bombs, called the lifespan study of Japanese atomic bomb survivors, is using really detailed dosimetry. They mapped where people were during the bombs, and they had the inner circle, people who were the most exposed, those doses were greater than 100 millisieverts. The next range of people who were between 2.5 and 10 kilometers, they had doses between 5 and 100, and then everyone else who was not in the city, not exposed. And they basically did careful dosimetry, which has gone on until recent years, and then linked these data to the cancer registries to estimate what were cancer risks in this population. So there have been many, many studies, and most recently they've been updated in the last 3 or 4 years. Basically, the median dose of survivors was 40 millisieverts. There are many people who died and their doses were far higher, but these are survivors in that range I showed you, 2.5 to 10 kilometers. The median survivor was in the ballpark of 40 millisievert, not so different from CT scan. This population has an increase in virtually every cancer type, leukemia, breast, and thyroid among the highest. The risk climbs within 2 years of exposure, but is elevated for their lifetime. Children are at greatest risk, and risks are elevated at doses above 10 millisievert, but no safe level. Overall, in the atomic bomb survivors, around 11% of cancer they've got are attributed to radiation exposure. The last information I wanted to share about cancer risks are from direct studies of CT scanning in children. This first paper by Pearson, Barrington, and Gonzalez was the first study published in The Lancet in 2012. There were 178,000 children in the UK who underwent CT between 1985 and 2002. They had cancers diagnosed through 2008. In this population, there were 74 leukemias and 135 brain cancers. Within 10 years of CT, doses of 30 to 50 milligray tripled the cancer rate. In our work, 10 to 20% of children receive the doses from a single scan. This graph shows the risk of brain cancer and leukemia based on brain doses and red bone marrow doses at baseline, and there's a linear increase in risk with exposure. There have been several publications from a group that calls themselves EPI-CT, which is a European study of CT scanning in children. These are data that are pulled from 9 European countries and the UK. They took data from the radiology information systems from 276 hospitals and linked with cancer registries in each country. Nearly 1 million children underwent at least one CT from 1977 to 2014. In this population, there are 165 brain cancers, 750 blood cancers, diagnosed with an average follow-up of 5 years. The brain cancer was just recently published in Lancet Oncology, and the hematologic cancers I saw at a recent presentation will be coming out shortly. Children with cancer had higher radiation doses, and basically the relative risk of brain cancer at a dose of 40 to 50 milligray, which I showed was average, is twice, and the same thing for hematologic doses. And there was a linear increase in the rate of cancer with increasing dose. So this graph shows the EPI-CT, shows brain dose on the x-axis, relative risk of brain cancer on the y, and there's a relatively linear increase in risk. UCSF is leading a study with several other health systems, including many KP studies, and Ontario, Canada, to assess the risk of radiation. We have 3.4 million children in the study and 37 million person years of follow-up. We've been following these patients for decades. We quantify in utero and childhood exposures. In our cohort, we have 6,000 plus cancers, 2,000 plus leukemias and lymphomas, and we have accurate estimation of organ doses, accurate assessment of cancer outcomes, and assessment of children with susceptibility syndromes, and we hope to have those results coming out shortly. I want to just point out something. I think it's important, which is that it makes sense that there'd be elevated risk of cancer from exposure to CT because of the biology. A very nice, albeit small study at Stanford studied 67 adult patients who underwent cardiac CT. There was extensive analysis to determine the biological impact. They did full gene sequencing, signaling, immunohistochemistry, and diverse markers of DNA damage and cell death were measured a day before and a day after the CT. The mean exposure of these patients were 30 millisievert, and they found significant changes in the expression of every measured marker in this study, showing that DNA changes were visible at 7 millisieverts and above in every patient. The risks are not equally distributed. Individual with cancer susceptibility syndromes are at higher risk. We screen patients with CT sometimes to look for cancers, but indeed we could cause the cancers that we're trying to detect for syndromes like Down syndrome or ataxia telangiectasia. These are syndromes where patients cannot repair DNA damage and the CT causes damage. There's an unfortunate well-known story in radiology of a well-known radiologist who underwent CT scanning. A radiologist's son who underwent CT scanning for mild trauma, and he developed 6 months later an aggressive brain cancer. And then on testing, the family was diagnosed with Li-Fraumeni syndrome. And so we need to lower doses for everyone or screen our children for syndromes before we do. I want to mention one study that a member of our team recently published on children with chronic diseases. She studied patients with pulmonary hypertension. Pediatric pulmonary hypertension is a chronic condition with high illness severity, although patients are living longer. Mahendra studied exposures for a small cohort of children at UCSF, 249 for a decade. Overall, in this cohort of children, there were 18,000 imaging exams, an average of 12 exams per child per year, and most in the younger children. And the average dose was 19 millisieverts, and she calculated this leads to an average increased cancer risk of 7.7% in girls, 2.9% in boys. So these risks were real, and these children are living longer. These risks have to be thought about carefully. We need to be vigilant and using CT scanning in children with chronic diseases to optimize. So can we reduce the radiation exposure? The US exposure to ionizing radiation has more than doubled in 20 years. CT scanning contributes the lion's share of the dose, and there are only two ways to reduce dose. First, to do fewer tests, ensure every test is justified, and make sure we substitute non-radiation modalities when possible. But the other way is to use lower doses, and that's really the focus of this meeting. My last slide is to point out how important this is. Will it really matter? For this study, we assessed radiation doses in children enrolled in Kaiser Permanente, Washington, a large HMO. We did a lot of direct data collection in this study. We pulled the actual studies. In this study, it's greater than 10% of children received a dose that would have tripled their risk of leukemia in prior estimates from the UK. We estimated in this study that in the US, in children in 2010, this will lead to nearly 5,000 future cancers. And if we reduce the highest outlier doses to the median, this should prevent 44% of those cancers, or 2,000. So lowering doses really will have an impact. I will end here and thank you for your attention. I think I'm just at time, but I think if there are questions, we can probably take one or two. So I'm looking at the questions. The first one is, would dose variations take into consideration the patient's BMI? The US tends to be higher weight with higher obesity rates compared to Europe. That's absolutely true. Any numbers that I show you on doses are adjusted for patient size, meaning we take into account the circumference of the patient's mid scan region. So if an abdomen scan is done, we basically measure their circumference in the midsection, and all the numbers are adjusted. And when we account for patient size, the BMI is close to what we're measuring, not precisely, but close. The differences become more pronounced rather than less. As sort of our extreme example, in Japan, there's a large difference in dose, and when we account for the smaller size, the difference becomes even larger, not smaller. The second question is on the calculations from CT. I assume they all came from simple conversion from DLP via K factor based on organ weighting. Do we know how much uncertainties there are? So excellent question. Our team has two papers published using, actually not using conversion coefficients, but rather generating them. We work very closely with a medical physics team at the University of Florida in Gainesville, Wes Balch, and most of our effective dose calculations come from his work. We've sent him detailed data on the scans that we have, and he uses modeling, mostly mathematical modeling, to estimate from each patient based on the region that was scanned, the scan length, their size, what the organ doses are, and then we add up the organ doses. So our effective dose calculations are based on this modeling. The K-factor paper, one was just published in adults, I think in European Radiology, and the other in pediatric, it's coming out in a pediatric journal, have shown that the K-factor, we've generated new K-factors based on 1 million of exams, are pretty good. And so I think I would recommend that people can use them safely, but our numbers are mostly the effective dose based on these detailed calculations. I think we will end here. I want to thank you all for your participation. And we will go on to the next speaker. And I don't actually have my program in front of me, so I'm not sure who is speaking next.
We have Dr. Pavlina Pike.
Fantastic. Welcome, Pavlina.